Good evening, dear APPS colleagues and friends. I'm Professor Wenju Song, speak in Taiwan. The current APPS president, Professor Anu Wang, not in this room now because she is very busy. So he asked me to give an opening speech of this November Grand Round. Firstly, a special thanks to the Professor Daniel Ng in Hong Kong. He is the founder of our APPS and also he is the main driving force behind this series of grand rounds. Daniel's dedication and outstanding contribution has brought all of us together and allow APPS and this program continue to develop and continue to grow. Then it is my great pleasure to welcome you to the 12th APPS Grand Round. Today's Grand Round is hosted by Taiwan team. Now I would like to express my great thanks to the host of today's Grand Round, Professor Mu. She is current president of Taiwan Pediatric Thoracic and Critical Care Society, and also Dr. Lin and Dr. Chen. All of them are the Taiwan team member of APPS. And finally, thank you all of you to join us from across different countries and time zone. Your presence makes this Grand Round valuable, and we look forward to continue and more seasons together. Now I pass the microphone to Professor Mu. Please, Professor Mu.
Okay. Thank you for Professor Song the introduction. Dear audience, good evening. We are very happy this time the case presentation being prepared and shared by our team from Taiwan. We would like to thank our good friend Daniel and especially for another good friend from Singapore, Professor ANCA, for spending so much time and effort to carefully review our preparation. Right now is a Thanksgiving holiday. During the holiday evening, we would like to invite everyone to warmly listen to the case we are ready and well prepared for you from Taiwan. Before we begin, we would like to introduce someone very important to me in Taiwan. He is a former president of the Taiwan Society Pediatric Pulmonology and Critical Care Medicine, and also a member of the APPS Executive Committee representing Taiwan. Let's give a warm welcome to Professor Dai Rengong to say some words for us. The Professor Dai, please.
Thank you. Dear colleagues, I think this is a good season. Happy Thanksgiving Festival. I am Dr. Rengong Dai from Taiwan, serving as an executive committee member of the APPS and the national ambassador for Taiwan, so-called International Society of the Pediatric Respiratory Disease. Our Taiwan Pediatric Thoracic and Critical Care Society, established in 1998, is honored to host the 13th Grand Round. It's my great pleasure to introduce today's moderator, Professor Mu Shuqi, President of our society in Taiwan, Chief of the Department of the Education at the Xinguang Hospital, and the Professor of the Pediatrics at the School of the Medicine, Huren University. Please let me ask all of us welcoming Professor Mu. Professor Mu, please.
Okay. Thank you, Professor Dai. Let me introduce our presenter here, the Dr. Chen Jiehe. Jiehe, he is graduate from National Taiwan University School of Medicine, get the Master of Public Health at Johns Hopkins University. He had attending physician Department of Pediatric Pulmonology, China Medical University Children's Hospital. Right now, he is a director, Department of Pediatric at Asia University Hospital. So welcome Dr. Chen. Please to start your presentation.
Hello everyone. Good evening. I'm Dr. Chen. I'm from Asia University Hospital in Taiwan, and I'm going to present my case. Okay, so this is my case, a 3-year-old female with recurrent respiratory distress. So I used to be work at China Medical University Children's Hospital as attending, and this is my ex-colleagues, Dr. Lin Jianheng, Song Wenju, and Dr. Lin Qingyuan. And a 3-year-old female, she's previously healthy, and 2 months prior to admission, she got COVID infection. 2 days prior to admission, she had a cough, rhinorrhea, fever, and she gradually had a short of breath. So on the admission day, she visited the local clinic, and while at the clinic, the physicians showed she had pale looking and respiratory distress. And so therefore, she was referred to China Medical University Children's Hospital Emergency Room Department. So at the China Medical University Children's Hospital Emergency Room, she had pale looking, tachypnea, and subcostal retraction, and there was no jaundice. Her vital sign was temperature was around 37.5 Celsius degree. Her pulse is around 165 beats per minute, and respiratory rate was around 36. Blood pressure was 80/54, and the saturation was 75% in room air. So the doctor at the ER put a non-rebreathing mask around 15 liters per minute for her, and her saturation returned to 95%. So because of her respiratory distress, and she was transferred to the PICU for further management. So this is her past history. Her birth history include a G1P1 gestational age of 36 plus 2 weeks by CS. She didn't have any allergy. Her immunization was up to date, and there was no influenza in the COVID vaccine before. She didn't have any previous hospitalization or surgical histories. She only had infantile eczema, and she had COVID infection 2 months prior to this admission. She didn't take a regular medication. And about her family history, his father has atopic dermatitis, and her grandfather had colon cancer. On physical examination, when she arrived at the PICU, she has very low saturation, around 89%. She looked acute ill, and her mental status was okay. Her body length and body weight was within normal limit. However, she had very pale and dry lips, and she had a decreased skin turgors, the heart rate beating fast, and there's an obvious chest wall retraction because of respiratory failure. So when we met these patients at the ICU, we emergent intubated the patients because of respiratory distress. And after the intubation, there are much fresh blood coming out from the endotracheal tube. So we started with home conventional ventilator, but we soon switched to high frequency ventilator because of severe respiratory distress. And the setting was quite high. The mean airway pressure can reach to 20 cm/H2O and very high delta P and frequency. Also, we found that she had a very dark brown urine after Foley insertion. So this is her lab data after admission to PICUs. So there's a little bit elevated white blood cells. The hemoglobin is very low. It's around 6.1 gram per deciliter. And there's an elevated reticulocyte count. And this is the saturation blood gas, which is quite fair, but actually she's in very high setting of ventilators. Also, she had a little bit mild elevated CRP. The renal function is okay, but the D-dimer is elevated. Besides, when you see the urine analysis, there's a acute blood, and the color is dark red, and there's a proteinuria. So this is the our case. Let's go through the pool one. What would you do to further investigate this patient? The first option is complete blood count, renal function test, urine analysis, microscope, and inflammatory marker, autoimmune antibody only, coagulation study alone, sputum culture and throat swab only, serum calcium and liver function. Let's get the pool. Okay, so most of attendants will choose autoimmune antibodies only.
Okay. That's great.
Okay, let's welcome our first panelist to discuss this session.
Okay, let me introduce the first panelist, Professor Anna Marie Nielsen. Now, Professor Anna Marie Nielsen is a senior consultant pediatrician and pediatric respiratory physician in University Malaya, Kuala Lumpur. Her undergraduate medical education was in Trinity College Dublin, and she has been a pediatrician and pediatric pulmonology for more than 20 years. He is trained in both pediatric respiratory and sleep medicine. So that's warm welcome, Professor Anna. Anna, please.
Thank you so much, Professor Wu, for your kind introduction. So let's go through the causes of pulmonary renal syndrome. So perhaps you all don't know, but actually pulmonary renal syndrome was initially called Goodpasture syndrome, described by Goodpasture himself in 1919. It was only in 1968 that it became clear that there were several different pathogenic mechanisms, and this led to the clinical syndrome of Goodpasture syndrome being abandoned and it being replaced by the term pulmonary renal syndrome. So pulmonary renal syndrome is when you have evidence of diffuse alveolar hemorrhage, as shown by symptoms of perhaps cough, perhaps hemoptysis, the symptom of or a symptom and sign of pallor, shortness of breath, and obviously when there's a significant hemorrhage, you will see hypoxemia. You will also see, you will also have evidence of glomerulonephritis. You may see hypertension. There may be peripheral edema, and in the urine may show hematuria and or proteinuria. Now, what's interesting is that sometimes the pulmonary symptoms or the renal symptoms may occur weeks apart, as seen in Goodpasture syndrome. So what would you find in the urine? So here you have the picture of all the different types of colors of urine. So you can have both microscopic and macroscopic hematuria, which would be looking like tea or coke colored. And you would see dysmorphic erythrocytes by using phase contrast microscopy. You may see red blood cell casts, or you may have proteinuria, which is classically described as subnephrotic. How about in the lung? If you're lucky and there's sputum, it may present with frothy, clotted, or watery sputum that can be light pink to dark red. As on the panel you see on the extreme left here, you could have a very prominent chest X-ray that looks like this with significant consolidation bilaterally and symmetrically. Or some patients may even present with a less sinister looking chest X-ray like this chest X-ray of my patient who came in with only anemia but no hypoxemia, but evidence of a cough and hemoptysis. If one does a CECT or HRCT, you will show this diffuse pattern, bilateral ground glass opacity, so GGO, and you may also have evidence of crazy paving. If you do bronchoscopy, you may see evidence of blood, as you can see in the carina here. And what is classic is that when you do a bronchoalveolar lavage, you will see increasing blood stain aspects in sequential samples, and it may be positive for hemosiderin-laden macrophages in cytology. One also must remember that it is very important to also do a scope of the upper airway as you do the lower airway, because you may want to catch these types of nodules or cavitating lesions, which would support the diagnosis of vagus, or what we call as GPA. So let's go back and look at this case summary. Does this girl really fulfill the pulmonary renal syndrome? She's 3 years old, so this is a little bit young. She's had COVID, so we know that COVID may actually predispose an autoimmune syndrome. She has a little bit of a cough and runny nose, which looks like some respiratory tract infection, but she comes with significant shortness of breath. There is pallor without jaundice, so suggesting that this cannot be a hemolytic anemia. There's respiratory distress and the saturation is very low. When you look at the middle panel here, you look at the chest x-ray, again, you can see some dense consolidation that seems to be more on the right than the left, but we can see there are still changes on the left-hand side. And what is important is that the doctors intubating her saw fresh blood. So this already gives an idea that, that there is diffuse alveolar hemorrhage, and that this drop in hemoglobin, hemoglobin of 6, with possibly looking more like a hypochromic microcytic anemia and a retic count that is high, suggesting that there is some prolonged bleeding in this chart. The eosinophil count is low. This would mean that the chances of having a Church-Strauss or EGPA is low. Looking at her coagulation screen, her INR is slightly elevated, but it is unlikely to be the cause of such a significant pulmonary hemorrhage. Her haptoglobin is low. This you will see sometimes if there's hemolytic anemia, and in D dimers are high if you see this in sepsis. Looking at her urine, and note that this was actually an incidental finding. Her parents did not complain of this. You can see very convincingly this coke-colored urine. But what is also interesting is that while the dipstick is positive for blood, the RBC microscopy was actually negative, suggesting a hemoglobinuria. But the protein is significantly high, 300 milligram per deciliter, and she's got a normal creatinine. So overall, the overall picture still fits that this is a definite case of PRS, as there's diffuse alveolar hemorrhage and glomerulonephritis as supported by the proteinuria. So before I dive into the differential diagnosis of PRS, this is important for me to remind the audience and myself as well that perhaps one of the first year investigation that one should do is make sure that urine analysis is actually done, so you catch these subtle cases of glomerulonephritis. So let's look at the differential diagnosis of PRS. So this can be divided into specific and non-specific. Specific causes would be posse-immune, whether it's global basement membrane problems, immune complex problems, or others. And non-specific PRS would be pulmonary disease complicating the kidney, or vice versa, kidney disease complicating the lung. And what is noted is that ANCA-associated vasculitis, AAV, accounts for most of the autoimmune cases of PRS. Next is actually anti-GBM disease or Goodpasture disease. So let's look at the specific causes of posse-immune cause for pulmonary renal syndrome. It can be divided into ANCA positive. It can be either JPA, JITS, or GPA. As you all know, some of you all may know it as vagus. It could be microscopic polyangiitis, MPA, or it can be eosinophilic granulomatous polyangiitis. Some of you all will know this as Church-Strauss. In ANCA negative, what is interesting is don't forget IgA nephritis, or commonly known as HSP. Under immune complex disease, we have SLE. Under anti-glomerular basement membrane, we have the well-known Goodpasture disease. And other causes that have been implicated are actually drugs. So what's the connection? What happens in ANCA-associated vasculitis? Basically, it is the injured or the damaged neutrophils, as you can see here. And what happens when they are damaged and as they squeeze through the blood vessels, they actually leak and leak a lot of enzymes, and these enzymes result in the formation of antibodies. And when these result in exposure of the subendothelial structures, these subendothelial structures elicit another more vivid antibody response that results in a lot of inflammation, and this inflammation causes all this leak in terms of the blood. How about in immune complex disease? In immune complex disease, what you have is antibodies that are actually directed against double-stranded DNA. And this will result in the formation and the deposition of immune complexes in the glomerulus as well as blood vessels, and again activating a pro-inflammatory cascade causing leaking of the blood vessels. How about how does a pulmonary hemorrhage happen in the lung? And this is due to the influx of interstitial neutrophil infiltrates. And these neutrophils are actually going very rapid apoptosis. And because of the very rapid apoptosis, the interstitium fills with neutrophils, edema, fibrin thrombi, and this results in a fibroid necrosis, well known as the necrotizing pulmonary capillaritis. When this happens, there's an impairment in the interstitial capillaries. This allows blood cells to cross the incompetent alveolar capillary basement membrane, and hence the result of DAH when the RBCs enter into the interstitial space and flood the alveoli with blood. Now let's go into the non-specific pulmonary renal syndrome. Pulmonary disease complicating the kidney could be pulmonary edema, could be due to a pulmonary thromboembolism, and could be pulmonary infection due to especially opportunistic infections like fungal infections. We also can have glomerular disease, which complicates the lung. Glomerular disease, which complicates the lung, which could be post-infectious, could be due to post-pneumococcus hemolytic uremic syndrome or even TTP, and could be amyloidosis post-cystic fibrosis. So there seems to be many causes of pulmonary renal syndrome, but really the most common causes of pulmonary renal syndrome are AAV, ANCA-associated vasculitis, anti-GBM, and SLE. So let me go through slowly this very busy table, which I took pains to prepare, because what I wanted to do was to compare certain identifiers that could help us clinicians when we are faced with these type of difficult children, and knowing that sometimes that these blood results will come back maybe 1 week or 2 weeks later. So firstly, when you look at most of these diseases like SLE, Wegener's, microscopic MPA, or Goodpasture's, Church-Strauss, or even HSP, you can see that majority of them actually happen during the second decade of life, except for HSP. When you look at the gender, it's majority of them happen in females, except in Goodpasture's, Church-Strauss, and in HSP. The pathophysiology I've actually gone through. Specifically, Wegener's is granulomatous disease. MPA is actually non-granulomatous. Goodpasture's is due to GBM against collagen fibers. Church-Strauss is also granulomatous, and in IgA is due to IgA immune complexes that are deposited within the alveoli and in the kidney. When you look at the investigations, we all know SLE, double-stranded DNA, don't forget doing the C3 and C4. In Wegener's, majority actually have ANCA anti-PR3 positive. In MPA, majority have ANCA anti-MPO positive. In Goodpasture's, although majority have anti-GBM, it's very interesting that some may actually have an overlap between, may also have some positive MPO ANCA. And in Church-Strauss, it's mainly ANCA anti-MPO. When you look at how they present, again, majority present with constitutional symptoms, fever, arthritis. When you look at their lung involvement, in SLE, although lung involvement is very common, intraalveolar hemorrhage is actually unusual. In Wegener's, besides the DAH or the pulmonary hemorrhage, they have these excavated pulmonary nodules. In MPA, they can have a catastrophic bleed. In Goodpasture's, sometimes the lung involvement can be asymptomatic. In Church-Strauss, it tends to be more severe asthma. And in IgA, it's also positive to have pulmonary hemorrhage. When you look at the kidney, majority have glomerulonephritis. When you look at the ENT or the upper airway, this is very commonly and probably diagnostic for Wegener's or GPA disease. If you look at the presence of peripheral neuropathy, this seems to be more common in MPA. When you look at the skin, majority of the AV have vasculitis, except for, of course, HSP, which tends to be in purpura, which tends to have purpura. And finally, when you look at other systems, you can see that GPA and MPA tend to have some abdominal symptoms. So finally, many people like to compare between GPA and MPA. And what again, you can see that GPA tends to involve more systems, and especially the ENT and the pulmonary system tends to have nodules and cavitary lesions, which is very unique. So that's done for me. So let's move on with the case.
Okay, let's keep our case. So our impression was acute pulmonary renal syndrome, and this is a differential diagnosis of cause pulmonary renal syndrome in children. So we did a further investigation at the anti-neutrophil cytoplastic antibody, which is ANCA, and it was anti-CANCA positive, and anti-MPO was negative, anti-PR3 antibody was positive. Her mother also had the anti-PR3 antibody positive. The anti-GBM antibody was negative, and indirect Coombs test was negative. Direct Coombs test was negative, which shows she did not have hemolytic anemia. So we started with methylprednisolone treatment, and we gave the patient's blood transfusion with PEC RBC. We arranged the bronchoscopy and the chest CT scanning. This is the finding of flexible bronchoscopy, and it shows intraluminal blood, and you can see there's lots of blood clots coming out from the distal airways. And this is the CT scans. So this is the residual hemorrhage, and also there are some GGOs of the lung fields. Our final diagnosis was CANCA vasculitis with PR3 positive antibiotics. We favor she had a microscopic polyangiitis. So this is the pool 2. How would you manage these patients? First, aldosterone monotherapy. Second, low-dose glucocorticoids alone. 3, high-dose glucocorticoids plus mepolizumab. 4, high-dose glucocorticoids plus rituximab. 5, intravenous immunoglobulin alone. Let's get to the pool. Okay, so most our attendees suggest that high-dose glucocorticoids plus rituximab.
Okay. Okay. Thank you, Jiehe, and thank you, Anna, for your presentation. Okay, let's move forward. The second panelist. First, our dear audience, please type your question in the chat room. Any question? Yeah, we can answer. The second panelist, Dr. Lin Jianheng, is currently serves as the director of the Division of Pediatric Pulmonology and Critical Care Medicine at China Medical University Children's Hospital in Taichung, Taiwan. His international clinical observationship at Stanford University and the Children's Hospital and UCSF, the Benioff of the Children's Hospital, and further enrich his expert in pediatric airway management and sleep medicine and critical care. So please join me in welcome the Dr. Lin Jianheng. Jianheng, please.
Thank you, Dr. Moose, kindly the introduction. Good evening, everyone, and thank you for joining this section. My name is Chen Hen Lim from China Medical University Children's Hospital. Today, I will provide an overview of the ANCA-associated vasculitis in children with a particular focus on pulmonary involvement. And I will also present several illustrative cases from our institution. And next. And ANCA and okay, next. ANCA vasculitis, also neutrophil cytoplasma antibody associated with vasculitis, is the necrotizing vasculitis affects small to medium-sized blood vessels, particularly in lungs, skin, and kidney. And there are two antibodies associated with this disease. The first is the PR3 ANCA and MPO ANCA are strongly associated with the AAV. However, they may be associated with different clinical presentation, and the PR3 ANCA is associated with the granulomatous vasculitis, and the MPO ANCA is associated with the necrotizing small vessel vasculitis. And we can see this figure, and this figure to highlight the two antibody is the PR3 and the MPO, these two kinds of the antibody, and the show clinical and the histology difference. Next. And the epidemiology overview, and this disease is rare in children, and the epidemiology is 0.5 per million according to a French study. And the female is the parents, the median age about 12 to the 40 years old. And the white is the race is more about the GPA, and the Hispanic Asian is with the MPA. And the symptom of the AAV is more can present with the unexplained pulmonary renal syndrome, systemic inflammation, or recurrent ENT disease with the constitutional symptom. And most of them, over 19%, and it had the renal involved, especially the MPA. And this disease had a high incidence of relapse, but most of them 5-year survival rate is high, about 17 to 80%. Next, please. And we can see three kinds of this disease. As we mentioned before, the first is the microscopic polyangiitis. Second is the granulomatous with polyangiitis. Third is the eosinophilic granulomatosis with polyangiitis. And all of this is affect the small or the medium size of the vessels. And the next, please. And the phenotype of ANCA serotypes, we can see these two kinds of the antibody. And the purple color is the PR3 ANCA, and they affect the upper respiratory tract, such as the ear, nose, and the throat, and also involve the kidney is about 50 to the 60% of the case. While MPO ANCA, the green color, they particularly affect the lung and the kidney. And we see there are many kinds of the cytokines associated with these two kinds of the ANCA disease. And we can see the tumor necrotic factor and the C5a and interleukin 6, interleukin 8, or B cell activating factor are in red, both the PR3 and the MPO ANCA. But the interleukin 10 is elevated only in the PR3 ANCA, but a decrease in the MPO ANCA. Next, please. And we can see these two kinds of the disease. As we mentioned before, the PR3 ANCA positive AAV is more associated with the upper respiratory tract, such as the ENT environment. And this kind of the disease is have poor long-term outcome, and there are a more a tendency to relapse. But the MPO ANCA disease is more often renal limited, and the prognosis is worse than the PR3 ANCA. Next, please. And we focus on the pulmonary manifestation in this patient. In the pediatric AAV patient, the most common symptoms were cough and followed by the pulmonary hemorrhage, shortness of breath, and the chest pain. And about 20% of them experienced respiratory failure, and even they were requiring invasive mechanical ventilation therapy. And if the patient had the MPA, and about 80% had lung involvement, and most of them presented with the aerial hemorrhage, especially the hemoptysis anemia. So if the patient presented with the unexplained progressive anemia, and we should consider is an indicator of a pulmonary hemorrhage. However, most of these AAV affected children had lung emulsification, completely recovery without significant pulmonary function impairment. And we should note that some patients had a seborrheic stenosis, and this disease is life-threatening, and is observed exclusively in patients with GPA. And this incidence of the seborrheic stenosis is higher in children with GPA, but about 16 to the 48%. Next, please. And the treatment, as mentioned before, most of these patients is the treatment is largely based on the data from the adult studies. And the remission induction, we use the glucocorticoids and the cyclophosphamide. And the rituximab is an effective as a cyclophosphamide. And the maintenance therapy is about the methotrexate and the azathioprine and others such as the MMF. It could be the maintenance therapy. Next, please. And back out to our patient. Next. And our case is involved if the patient involved ENT or involved granuloma or PR3 ANCA, we should consider the GPA. But if the patient has a diffuse alveolar hemorrhage and the MP or ANCA positive without ENT involved, we should consider the MPA. And in our case, the C-ANCA is positive with the PR3 antibody positive. So we favor our patient had the microscopic polyangiitis. And this patient had a presentation with the mild fever, tachypnea, and a cough. And we traced her history, and the patient had COVID-19 2 months ago. And if the COVID-19 is the trigger factor of this patient, we don't know because we have not exacted the improvement of this patient. Next, please. And we can see the Berman-Hamlin vasculitis score to check this to see if this patient is mild, moderate, or severe. In our patient, and we can see 9 organ system assessment. Our patient had a mild fever and had the chest involvement, pulmonary hemorrhage, and had the renal involvement such as the proteinuria. So the total score of the Berman vascular score is about 9, and it is the moderate activity. Next, please. And the treatment in our case, we use the methylprednisolone initially for the and then we use the induction therapy such as the rituximab, azathioprine, and hydroxychloroquine, and the MMF. And the maintenance, we use the methotrexate and the MMF for the maintenance therapy. Next, please. And we also talk about the previous 2 cases in our hospital. The first is a 7-year-old girl had an iron deficient anemia history for 4 years, and she presented with a progressive dyspnea for months, and the chest X-ray showed diffuse pulmonary hemorrhage, and then intubation was done due to the respiratory failure. And the lab data show positive finding with the p-ANCA MPO antibody. And then the diagnosis of this patient is the microscopic polyangiitis. And she recovered with a regular immunosuppressive therapy. And the second case is a 10-year-old girl and presented with the hemoptysis and the bilateral leg swimming. She also had a glomerulonephritis and was treated with the not only immunosuppression therapy, but also hemodialysis. And the third case is this case. Next, please. We can see this table, and all three these patients had all of them are female, and one had the iron deficient anemia, but another two patients have no anemia history. But the initial presentation, two of them is hemoptysis, and our case had a shortness of breath without hemoptysis. But after bronchoscopy, we can see the pulmonary hemorrhage. And the antibody we can see positive in the first two cases is the p-ANCA and PO antibody. But our case, the third case is the c-ANCA PR3 antibody positive. And about the renal involvement, the first case had no renal involvement, but the second and the third case had the renal involvement. Especially the second case had rapid progressive glomerulonephritis, and she also under the hemodialysis. Next, please. And the concluded take-home message is that the ANCA-associated vasculitis is an uncommon multisystemic disease in children, and it should be considered in any child presenting with a pulmonary hemorrhage and unexplained anemia. And the timely administration of the high-dose methylprednisolone plus therapy followed by rituximab can effectively suppress disease activity. Management can be highly challenging, particularly when the pulmonary hemorrhage and the glomerulonephritis occur concurrently, even in very young patients. With early and aggressive treatment, complete remission of both the pulmonary hemorrhage and the glomerulonephritis is achievable. And this is my presentation. Thanks for attention.
Okay, so thanks, Dr. Lin. And this is our treatment course. So we started with methylprednisolone mini-pulse therapy. And we also gave the patient rituximab, IVIG. And the patient stopped bleeding 2 days later. She was extubated smoothly 1 week later. And she was discharged 2 weeks later with MNF, tacrolimus, and the prednisolone for maintenance therapy. So this is her X-ray on day 2. So you can see there's a ground glass infiltration of both lung fields. And this is her X-ray on discharge day. It became much clearer, and she was attubated. She breathes pretty well. So let's have a pool 3. What monitoring will you do in the future? 1. Stop monitoring after remission. 2. Annual visit only. 3. Monitor only ANCA titers. 4. Regular follow-up chest X-ray, hemogram, ESR, and ANCA test, urine analysis. Okay. So obviously, most people choose D, regular follow-up at every laboratory data you can. So let's welcome Professor Teo Wu Hu for our panel 3 discussion.
Okay, let me introduce the third panelist, Professor Tao O Hu. The Professor Tao is a clinical associate professor, is a senior consultant in pediatric respiratory medicine at KK Women's and Children's Hospital. His clinical interests include asthma in children, pediatric flexible bronchoscopy, and pediatric cardiopulmonary exercise testing. So let's welcome the Professor Tao.
Thank you, Prof. Mu, for the introduction. Good evening, everyone. I will be speaking on the follow-up management of AAV in children. You can hear me, but I think somehow I'm having problems with trying to show my video. Can you see my video? Okay, no worries. So long as you can hear me, and I can see the slides, right? And okay, so As we know, pediatric AAV can present with one or more organ systems involvement initially, followed by other different organ systems being involved months to years later. So its assessment must really cover all the organ systems that may be involved. And also being a potentially debilitating disease, the child's overall functioning and health must be assessed. So broadly, the assessment can be divided into three important components. Number one, disease activity, referring to the clinical manifestations caused by the underlying inflammatory process, which is often treatable by increasing immunosuppression. Number two, organ damage, referring to the structural and functional consequences of the disease, which are often not reversible and unlikely to respond to increased immunosuppression, and may therefore require other management, including physiotherapy, occupational therapy, or sometimes even surgery. And of course, lastly, treatment adverse effects and comorbidities. So that was the question that I saw in the poll, in the Q&A earlier on about how long these children need to be on immunosuppression. Is it lifelong? Okay, so to answer this question, as shown in this diagram, the current consensus recommended treatment for AAV in children can be up to 6 months for remission induction, okay, and also up to 4 years, 2 to 4 years, okay, for remission maintenance. And this this definitely involves the use of immunosuppressive medications that you see here. So one of the most important aspects of follow-up management would be the prevention and early treatment of infections. Prophylactic vaccine is usually recommended and should be discussed with the parent and the patient for the prevention of Pneumocystis jirovecii and other infections. Now, this is a table showing the definitions of outcome assessments. You can see that ESR, CRP, okay, as well as two clinical scoring tools, the PVAS, which is the Pediatric Vasculitis Activity Score, and the PVDI, the Pediatric Vasculitis Damage Index, are measures that are used in the definition of some of these outcomes. So, for example, for inactive disease, the PVAS should be 0 and the ESR and CRP normal. For a person to be termed in remission, the inactive disease must be at least 3 months and on very low dose corticosteroids. A relapse, a major relapse especially, is defined as a new or recurrent appearance of life-threatening disease activity, and disease damage can be quantified by the PVDI. So this is the PVAS, which is adapted from the Birmingham Vasculitis Activity Score, BVS, for adults that you saw earlier on, shown by Dr. Lin. So the PVAS has been validated for use, and the changes in the PVAS score reflects disease activity and can be used to guide adjustments of immunosuppressive therapy. So this score is divided into major categories by system, as you can see, and under each category, the active conditions to look out for are listed. So for example, under general, we can have fever or weight loss. Under cutaneous, there can be polymorphous erythema or panniculitis. And of course, we can have the cardiovascular and abdominal system. So under mucous membranes and eyes, we often get mouth ulcers, okay, and for red eyes due to episcleritis or conjunctivitis. Under ear, nose, and throat, there can be nasal discharge, ulcers, or granuloma. Under renal system, proteinuria or hematuria. And of course, there are conditions under the nervous system as well. So for pulmonologists, the chest, there can be nodules, cavities, or pleural effusions on the chest X-ray or CT chest. So now the way to use the PVAS is to tick the active box only if the abnormality is due to the active vasculitis is newly present or worse over the last 4 weeks and persisting for less than 3 months. So each of these active items are assigned individual scores that are summed up to a total score that again you saw in the presentation by Dr. Lin earlier on. Right? So, okay, so this is the Pediatric Vasculitis Damage Index, okay, which is adapted from the Vasculitis Damage Index for adults. So, a word of note is that the PVDI is currently ongoing validation, but has been used in a recent published study on pediatric vasculitis. So similar to the PVAS, it is divided into major categories by systems with the corresponding damage in each system listed. The important point to note for PVDI is that the vasculitis damage is defined as the presence of the irreversible features, and they must be present for at least 3 months. So, for example, for musculoskeletal, for under musculoskeletal system, significant muscular atrophy has to be present for at least 3 months. Similarly, for skin and mucous membranes, the chronic mucosal ulcers have to be recurrent or persistent and requiring therapy and lasting for at least 3 months. So the other systems include the ocular system, and under the ENT system, you can have nasal bridge collapse, okay, saddle nose, or subglottic stenosis requiring surgery that we see in GPA. Okay, and again, under the chest, for pulmonologists, we can see sometimes pulmonary fibrosis with consistent symptoms and signs and confirmed radiologically or by lung biopsy. There can also be pulmonary hypertension with consistent symptoms and signs again, and they must be confirmed objectively as well. So under cardiovascular system, we have a longer list than the others, and so the cardiac conditions are listed on this slide. Okay, and on this slide, you can see that they're all vascular conditions for under the cardiovascular system. And we can have also involvement in the abdominal system as well as the renal system. And with the renal system, end-stage renal disease is a feared long-term complication in AAV. So under neuropsychiatric system, there can be cranial nerve palsy or peripheral neuropathy. And again, this must last at least 3 months. So specifically for pediatrics, under others, okay, you can see that we also have items like delayed puberty, growth delay, and failure to thrive. And these are additional items in the PVDI that is not present in the adult VDI. And of course, school attendance is an important part of childhood. And so this is also actually included in the PVDI. So actually, basically, if you look at it another way, the PVDI is basically a comprehensive list of all the potential long-term complications of AAV disease, its comorbidities, and the treatment adverse effects. So now, consolidating all that has been mentioned in the earlier slides, these are the general recommendations that I have put together from various guidelines for AAV. So follow-up reviews should be more frequent, every few weekly for a few months after admission for an organ or life-threatening disease, and at least 6 monthly in the first few years after remission, then at least annually. Right? History and physical examination should include BP and vital signs, growth parameters, pubertal status where relevant, and assessment of disease activity and damage using the clinical tools like PVAS, PVDI, or equivalent where available. As mentioned by Anna earlier on, urinalysis, including microscopic examination, is critical. For blood tests, they are pretty basic, okay? So they include full blood count, okay? Sometimes with B-cell lymphocyte subpopulation if needed, ESR and CRP for disease activity and infection, liver function test and renal panel to assess for organ involvement and toxicity from treatment, okay? ANCA, PR3 and MPO should be done at diagnosis and at intervals while on treatment or when there are concerns with relapse. The specific protocol may differ between centers, but it is important to note that while rising or persistently elevated ANCA levels may be a risk factor for relapse, this is not consistently predictive, and so therefore, treatment should never be escalated based on ANCA trends alone. So other assessments include lung function tests every 6 to 12 months if the child is 6 years and older. And I will show you why I think this is important with a recent study later on. Right. So organ-specific tests should also be done as clinically indicated. And for pediatric pulmonologists, this would be chest x-rays or CT chest, depending on the situation. Again, it is important to also monitor for treatment-associated toxicity that you see listed here in this slide. This require regular clinical and laboratory monitoring, which are mostly already mentioned in the earlier few slides that I've shown. Additional investigations may need to be done for the evaluation of diabetes, osteoporosis, or malignancy. So if cyclophosphamide is used for treatment, It is also important to consider and discuss fertility preservation in pubertal patients. So a few words on rituximab. Rituximab is gaining popularity as an option for AAV treatment, so it is important to be aware of its adverse effects. So as a result of CD20 positive B cell depletion, rituximab may induce hypogammaglobulinemia and it can increase vaccine efficacy. And so as a result, this may increase the risk of life-threatening infections. So therefore, it is recommended that serum IgG, A, and M be measured before each rituximab administration, and if low, may require a discussion with the immunologist regarding IgG or IVIG replacement. It is always best to vaccinate before initiating rituximab, but as we know, often in real life, the clinical situation may not allow so. So the general recommendation for any vaccination that is required after initiation of rituximab is to vaccinate at least 6 months later after the last rituximab dose and 4 weeks before the next course if the disease activity allows. And live vaccines are not recommended until B cell repletion occurs. So I want to touch a little bit about relapse risk factors. Okay, so the data from mostly adult studies actually do suggest that the closely related risk factors of PR3 positivity, GPA diagnosis, and the presence of ENT disease diagnosis predict for higher risk of relapse on follow-up. And as mentioned earlier on, ANCA trend may also predict higher risk of relapse. But remember, unfavorable ANCA trend alone cannot be used to guide the escalation of therapy. Okay, however, still on the topic of risk factors for relapse, this recent publication that is based on about 400 children and adolescents with AAV from the archive and Pediatric Vasculitis Initiative Registry actually shows interesting finding. So they showed that by 1 year, there were actually no significant difference based on the ANCA positivity and PR3 or MPO positivity in the likelihood of the subjects achieving inactive disease, as you can see on the table on the left in different shades of green, experiencing improvement or acquiring damage. Also, in contrast to adult onset AAV, there was no significant difference based on, again, ANCA positivity and PR3 MPO positivity in the likelihood of the subjects having a relapse between 1 to 2 years after diagnosis, as you can see here in the beige column. So this difference in findings from those of historical adult AAV studies may be due to a few possibilities, perhaps different study methodology, and of course, definitely with time, there has been evolution and improvement of management for AAV, and also the fact that in this study, the follow-up period is relatively short for only up to 2 years. So moving on to another pediatric study that's quite recent that is focusing on pulmonary manifestations and outcomes of AAV. This study of about 38 subjects identified cough and pulmonary hemorrhage as the most common pulmonary manifestations and showed that up to about 82% of CD chest, if done, were abnormal, with nodules and ground glass opacities being the most common. They also used clinical and objective assessments, and they reported that at 6, 12, and 13 months of follow-up, about 62, 39, and 29% of subjects continued to show pulmonary manifestations. And interestingly, the investigators also found that the subgroup of young MPA patients in the study experienced repeat pulmonary hemorrhage. So this is a deeper dive into these few children that they mentioned. So as shown in this table, these 5 subjects of a mean age of 3.7 years, they were all MPO positive and diagnosed with MPA and presented initially with only respiratory manifestation without renal involvement. They have a relatively high mean pulmonary hemorrhage relapse of about 2.4 episodes over 3 years. And interestingly, all of them were also either Hispanics or non-Hispanic African Americans. And the investigators in this study reported that there is a high representation of Hispanics and non-Hispanic African Americans in their study, which was consistent with the geographical demographic the hospital serves. So I think this difference in the finding from the other adult and the pediatric studies may be due to the influence of the genetics of different ethnic groups, the environment, and other social determinants of health on the pathophysiology of AAV. And so if you consider this and the other findings of the previous study that I've shown, the message here is that while certain risk factors may predict the disease course, this may not apply to all age groups and all populations. So as clinicians, I think it's very important that we carefully assess each child with AAV with an open eye. Okay, so as mentioned earlier also as well, as you can see within the green boxes in the two charts on your right, this is for MPA, this is for GPA, over 3 years of follow-up. The good news is that an increasing number of subjects had no pulmonary manifestation, so most do get better. Okay, also as shown with the blue boxes, the subjects with MPA in this study had rebleed events and oxygen needs, whereas interestingly, those in the GPA group was relatively unaffected. In terms of objective assessments of the subjects old enough to perform lung function tests, less than 10% actually demonstrated obstructive or restrictive defects. And in fact, if you look at the blue boxes that I've highlighted, all of them actually had obstructive and not restrictive defects, which is pretty interesting in this study. What is striking to me also is that overall, about 50%, as they quoted, okay, of the subjects at any time demonstrated diffusion defects. These diffusion defects were mostly mild, they stated, as you can see in the beige boxes right here. Yeah, to me, this is important as it shows that even without obvious rebleeds, okay, for the GPA group, right, what you're seeing is that the subject can still end up with diffusion defects. And this could reflect actually damage from the initial pulmonary presentation that was very slow to recover. Or perhaps, another way to think about it is that there could be ongoing subclinical pulmonary manifestations that were not apparent in the GPA group. So the authors did acknowledge some limitations with their findings for diffusion defects, but regardless, I think as pediatric pulmonologists, we have to be vigilant in the screening for pulmonary inflammatory activity with objective assessments, which is why I think actually pulmonary function tests are actually quite important. Right, so I'll quickly go through the last few slides. Long-term complications, as mentioned at the start, are actually all the conditions listed in the PVDI. The conditions that you see here by systems are the more common and more important long-term complications in AAV. It is also very important to remember that AAV patients on treatment are at risk of life-threatening infections. And we have to be aware that the mortality can also be often from the renal or pulmonary complications of AAV. As with any serious chronic disease, reduced quality of life, anxiety and depression, and other mental health concerns are very real for the patients and their families. So screening and access to mental health support is critical for good treatment adherence and outcome. Multidisciplinary care with effective interprofessional communication is critical. And here I want to take the opportunity to highlight that our non-medical nursing, allied health, and social service colleagues also have very important roles to play as well. And lastly, if pediatric AAV patients are managed well, they will grow up to be adults, and transition of care is an important process that should be thought of and planned for when the child is about 14 to 16 years old. So in summary, optimal long-term follow-up of pediatric AAV patients involves thorough, multi-system clinical and objective assessments for disease activity, damage, and treatment of adverse effects. So the PVAS and PVDI may not be used routinely by all centers, but they can serve as actually very good guide to the range of AAV and treatment-associated conditions that we need to keep in mind in the long term. So, and with that, I thank you for your attention.
Okay, thank you.
Yeah.
Okay, let's back to our case. So she had two similar episodes of disease flare-up 6 months after first discharge, and we gave the patient same regimens, rituximab and methylprednisolone for induction. And because she had a relapse, so we switched our maintenance medication to the allotriopin and hydroxychloroquine, as well as prednisolone, and we tried to gradually taper prednisolone dose. However, even in this regimen, she still have some minor flare-up, and then we switched to MTX and NNF for steroid sparing. And this time the result was quite good. She did not have active disease for more than 1 year, and she had no more hematuria and pulmonary bleeding. And during her maintenance course, I do have given the patient a Bacta for prophylaxis for PJP infection. And this is the picture when I meet the patient 2 weeks ago. I went to her kindergarten, and it was the Thanksgiving is coming, so I took a picture with her. She's quite well, and she's only taking oral medication. And right now she's 5-year-old, and she breathes pretty well. So let's back to our patient for overall review. This is a case of PR3 positive vasculitis with pulmonary hemorrhage, proteinuria, hematuria, and acute respiratory failure. She was successfully treated after rituximab and steroid therapy, and we gave the patient IVIG supplement for prevention of hypoglycemia and infection. And we maintain therapy with allotriopin and the NNF. So thanks for your listening.
Okay, thank you for Gerhard's presentation. It's our great pleasure to meet all audience online, especially at Thanksgiving holiday night. Bring our greeting from Taiwan. Wish you already enjoy your learning treat. We will prepare a case talk about the ANCA vasculitis associated renal pulmonary syndrome and presenting initially pulmonary hemorrhage. Thanks again for Professor Anga and Faces for technology assistance. So, Anga, yeah, would you please say hello to audience? Okay, back to we need a closing remarks. Let's welcome the Dr. Omidra Narayan, for two closing remarks. The Dr. Omidra, please.
Thank you very much, Professor Mu. And I would like to thank all the presenters, Dr. Chen, Professor Soong, Professor Ho, Professor Dai, and Professor Nathan, along with Dr. Lin, for an excellent presentation. And I know how challenging these cases can be. And we also know that it's quite rare to have in younger children such pulmonary renal manifestation. So excellent management by the team and excellent panelists, the insights that we gained today. So thank you all. Two announcements I have to make, that in January, on 30th of January, it will be the UAE team and it will be our resident, Dr. Hibat, who will be presenting a case. And we have given the topic as breathing through a straw and how it has been tackled and the challenges around that. So please do join on 30th of January in the new year. And I look forward to meet all of you or most of you in Hong Kong in the next apps conference, which will be either in October or November. The date hasn't been finalized yet by Dr. Daniel and the apps committee. So, but we do look forward. Please mark your calendar. It will be sometime in end of October or November in Hong Kong. Thank you so much and see you in January.